Let's begin with the first section of gastrointestinal neuroendocrine tumors. And in this section, we will talk about the overview of gastrointestinal neuroendocrine tumors, what's the pathology, and also we will discuss the classification and features of gastrointestinal neuroendocrine tumors. Gastrointestinal neuroendocrine tumors are the tumors that are derived from diffuse neuroendocrine system of GIT, and they are composed of amine and acid producing cells with different hormonal profiles depending on site of origin. So gastrointestinal neuroendocrine tumors, as the name show, they develop from the neuroendocrine system of gastrointestinal tract, and they are composed of cells which produced amine and acid, and they have different hormonal profile also, because whenever there is the term endocrine is the system of hormones and glands. So hormones are different, as hormones are also associated with this, because depending on the site of origin of the tumor from where it develops. So composed of diffuse neuroendocrine system of GIT derived from the cells which produce amine and acid. Originally, they were classified and known as epidermomas, but this term is no longer used now. So epidermomas is now gastrointestinal neuroendocrine tumors. Two categories are present. One is GI neuroendocrine tumors, which are present in gastrointestinal tract, and the other type is pancreatic neuroendocrine tumors, which are present in the pancreas. So two major categories. One is that is associated with gastrointestinal tract, and the other one that is in the pancreas. So two types are present. Pathology is the cells which are present in the neuroendocrine tumors. We have small round cells with uniform nuclei. So you can see the cells are small, round, but the nuclei are uniform nuclei. Mitosis in these cells is uncommon, it's not common. So division by mitosis is not common. Identified on routine histology by silver staining. So identification is done by silver staining of these neuroendocrine tumors. The immunocytochemical localization, what are the substances used for cytochemical localization, or what different chemicals use? We use chromogranins A, B, and C, neuron-specific enolase and synaptophysin. Among these, the chromogranin type A is commonly used. So the cells in this are round with uniform nuclei. Mitosis is uncommon in these cells, and usually the identification is performed by silver staining, and then cytochemical localization is by chromogranin A, B, C, neuron-specific enolase and synaptophysin. These are some chemicals used for the immunocytolocalization. Electron dense neurosecretory granules are present in this that cause production of the secretions. Small clear vesicles synthesize peptides, growth factors, bioactive amines, give rise to clinical syndrome and clinical feature identification for diagnosis. So some other pathological features, we already said that silver staining is used for the identification. Then we have some other chemicals used for cytochemical localization, and then they have electron dense neurosecretory granules that cause secretions. They have small clear vesicles present, and these vesicles or the neurosecretory granules produce peptides are produced by these tumors, growth factors and bioactive amines. They give rise to production of these substances, are responsible for different features of these neuroendocrine tumors, and they also clinical feature diagnosis, identification is important for diagnosis of these tumor. Classification, we have depending on the area of the which is involved, we have foregut, in which the classification in the foregut there is low serotonin 5-hydroxytryptamine content, argentophin negative but agyrophilic cells are present, secrete ACTH or 5-hydroxytryptamine, cause atypical carcinoid syndrome, and they are multi-hormonal. Metastasize to bone. So classification of these gastrointestinal neuroendocrine tumors is on the basis of whether the foregut is involved, middle portion of the gut is involved, or the hindgut is involved. If the foregut is involved, then they have low serotonin content, argentophin negative, they secrete ACTH or 5-hydroxytryptamine, multi-hormonal, and these metastasize to bone, which is in the foregut. Now the midgut, they have argentophin positive now, high serotonin content, 8 cause typical carcinoid syndrome or metastasis, release serotonin and tachykinins, rarely secrete 5-hydroxytryptamine or ACTH, less commonly metastasize. Now, there are very important differences between the involvement of foregut and the midgut. Midgut is argentophin positive. They do not metastasize, less commonly metastasize, release serotonin and tachykinins, and rarely secrete 5-hydroxytryptamine or ACTH. Now the hindgut. What are the features if the tumor involves the hindgut? They are again argentophin negative like foregut, agyrophilic, rarely contain serotonin, rarely cause carcinoid syndrome, rarely secrete ACTH or 5-hydroxytryptamine, contain numerous peptides, may metastasize to bone. So all these sites, whether foregut, midgut, hindgut is involved, they have important differentiating features, and differentiation between these features help to find out which part of the gut is involved or affected by the tumor. 9 well-established specific functional syndromes Very rare specific functional syndromes, 6. 5 possible specific functional syndromes and non-functional pancreatic neuroendocrine tumors. So the other classification, one was involvement of foregut, midgut, hindgut. The other classification is according to the presence of specific functional syndromes. If 9 are present, if 6 are present, if 5 are present, and then no specific functional syndromes are present, non-functional, which is pancreatic neuroendocrine tumors. Features are secretion of peptide tyrosine by intestinal ovarian tumors. So there is secretion of tyrosine, peptide tyrosine. And then there is altered gut motility, constipation, ovarian tumors secreting renin and aldosterone, alteration in blood pressure, and somatostatin causing diabetes or reactive hypoglycemia. These are all the clinical features associated with the tumor. There is altered motility, constipation, ovarian tumor secreting renin and aldosterone. Then there is changes in blood pressure and somatostatin causing diabetes or reactive hypoglycemia. Non-functional pancreatic neuroendocrine tumor. Non-functional was at the end of the classification. We have first the 9 specific features, then 6, 5, and then non-functional pancreatic neuroendocrine tumors. Non-functional is misnomer in strict sense because those tumors frequently ectopically secrete a number of peptides, pancreatic polypeptide, ghrelin, neurotensin. However, they cause no specific clinical syndrome. So non-functional, they say it's not non-functional, it's a misnomer because they produce certain substances including polypeptides, ghrelin and neurotensin, but they are non-functional in the sense that they do not cause any syndromes, specific clinical syndrome, but they do produce some chemicals or number of peptides. These are all the peptides. But these pancreatic neuroendocrine tumors do not participate in the specific type of clinical syndrome. They ectopically secrete polypeptide, 60 to 85% polypeptide. Then we have a neurotensin, 30 to 67%. Calcitonin, 30 to 42%, to lesser degree ghrelin, which is 5 to 65%, and also referred to as PPomas. So PPomas. So these are some peptides produced by the pancreatic neuroendocrine tumors: polypeptide, neurotensin, calcitonin, ghrelin, and they are also known as like epidomas. They are known as PPomas. Gastrointestinal neuroendocrine tumors. In almost any GI tissue, they can develop 64%. So any gastrointestinal tissue is affected by intestinal neuroendocrine tumor, and 64%. In respiratory tract, it can be present in 28% of cases. 70% would originate at bronchus, jejunum, ileum, or colon. Race important for rectal carcinoid. Females have low incidence. So gastrointestinal can involve any tissue of GI tract. It can also occur in respiratory tract and most commonly occur in the bronchus, jejunum, or colon is the site where they are mostly present. It's rare. Race is very important for rectal carcinoid, and they have more. Female have low incidence of gastrointestinal neuroendocrine tumors. Locations now location percent of total, incidence of metastasis and incidence of carcinoid syndrome associated with different sites of these tumors in the foregut. These are the structures present in the foregut. Esophagus, less than 0.1% of total is present in esophagus. Incidence of metastasis is not present, and incidence of carcinoid is also very little, about 0.1 or up. Then stomach, 4.6%. Incidence of metastasis is 10 and carcinoid syndrome is 9.5. So stomach, it's very high risk of metastasis and carcinoid syndrome. Duodenum, 2, and then incidence of metastasis is not, and then 3.4 of carcinoid syndrome. Pancreas, 0.7. Metastasis 71.9% and carcinoid syndrome is 20%, so it's big percentage. Gallbladder 0.3% location, 17.8 is the incidence of metastasis, 5 is the incidence of carcinoid syndrome. Then we have bronchus, lung, trachea. 27.9% is the site of location total, 5.7 is the metastasis, 13 is the carcinoid. So if we just look at the foregut, the highest incidence of is the location is bronchus, lung and trachea, 27.9%, and 13% can lead to carcinoid syndrome. So very commonly it is present in bronchus, lungs and trachea as compared to other foregut abdominal organs. Then midgut, again, these are some values given in which we have jejunum, ileum, Meckel's diverticulum, appendix, colon, liver, ovary, testes. And if we see here, there is 50% incidence of carcinoid syndrome associated with testes, 50 for ovary, but most common site of development of location is usually the ileum here. 14.9% is in the ileum. Then the hindgut, which has rectum, then 13.6, and the carcinoid syndrome is not present, and the metastasis is 3.9. So if we just briefly summarize this chart, foregut is very common in the location is common, is bronchus, trachea, lung is common. In the midgut is the ileum is common, and then we have the colon. Then in the rectum, it can metastasize, but there is no carcinoid syndrome, and 13.6% is present in the rectum. Pancreatic neuroendocrine tumor is a misnomer entirely in pancreas. So pancreatic neuroendocrine tumor is a misnomer because it's entirely in the pancreas at both pancreatic and extrapancreatic sites, also called islet cells tumor. That's the histological picture of pancreatic neuroendocrine tumor. New classification is based on a grading system, and this new classification is based on how the cells are well differentiated, which is low grade, and poorly differentiated is high grade, and small cell carcinoma is in high grade. And then we have large cell neuroendocrine carcinoma and pancreatic neuroendocrine tumors. So new classification is based on the differentiation of the cells. If they are well differentiated, is low grade gastrointestinal tumor, well differentiated. But if it's poorly differentiated, it's called high grade tumor, and they can be small cell tumor or large cell tumor. Large cell tumor is of pancreatic neuroendocrine tumor. Pancreatic tumors have poor prognosis, that's why they come under the high grade, poorly differentiated type of tumors. And also gastrointestinal neuroendocrine tumors, which leads to carcinoid syndrome, which is large cell neuroendocrine carcinoma. So that was all about section 1. Thank you for watching sqadia.com.